Right. Hi guys, welcome back. So if you're giving the FMG exam, next 30 minutes are going to be important because we're going to discuss 10 important image-based questions. Now, when it comes to medicine, images are not very important. Now you may think what sir is telling, but please remember, most of the questions where image is included and the question is coming from medicine, mostly the answer will be based on the context or the history. Image is just an add-on feature. From pathology and radiology, yes, there will be a lot of image-based questions, but medicine, majority of the image-based questions, history holds the key. Image is just one addition. Even if you're not able to make out from the image, you can still answer if you know how to interpret the history or story. Anyway, let me go through the first image without taking much of your time. ECG and X-rays, that's all in medicine or some clinical science, that's it, right? So starting with the ECG, this is the first question. And as I've already told you, every image-based question has to be analyzed from the context. So here is the context. A patient with frequent attacks of palpitations and ECG is here. So whenever we think of palpitations, what all conditions come to our mind? Mainly we think of arrhythmias, right? Arrhythmias. And if the patient is going through recurrent attacks of palpitations, that means he's probably going through recurrent attacks of arrhythmias. Recurrent attacks of arrhythmia. So we should always keep in mind that some condition which increase the risk of developing arrhythmias may be responsible, and that is what examiner may be looking for. So we are primarily dealing with recurrent arrhythmias. So now tell me what all conditions are known to cause recurrent arrhythmias. One such condition which an FMG student must know is WPW syndrome, right? WPW syndrome. Okay. Then second one is arrhythmogenic right ventricular cardiomyopathy or dysplasia. Okay. The third one is hypertrophic obstructive cardiomyopathy. Okay. The fourth one is heart failure. Patients with heart failure are also at increased risk of developing recurrent attacks of arrhythmia. So at least the context is set. Someone with recurrent attacks of arrhythmia, that's a story in the question. These are my possibilities. So I have to see in the ECG, do I get any findings suggestive of this? Can I diagnose heart failure with ECG alone? No, it has to be diagnosed with the N-terminal pro-BNP and ejection fraction. So of course, it's not going to be an image-based question, right? HOCM, ideally diagnosed with the echocardiography. There are some ECG findings, not important. WPW and ARVC can be diagnosed from the ECG. At the level of FMG, unlikely that they will ask ARVC. Mostly they will ask WPW syndrome. So always remember, if the question says recurrent attacks of arrhythmias and you get an ECG, first thing you should do is apply the findings of WPW syndrome. Whether they are present in that ECG, present, that's your answer. Okay, I'll come back to this ECG, but first we will understand the WPW syndrome. We call this WPW syndrome as pre-excitation syndrome. Why we call it as pre-excitation syndrome? Normally, when SA node acts as a pacemaker and sends an electrical impulse to the ventricle for the ventricle to contract, it can only pass through the AV node. There is no other point of entry for this electrical impulse into the ventricle, because the cells between the atria and ventricle are lined by tight junctions. They do not allow the passage of electrical impulse. Only pathway is AV node. But these people of WPW syndrome are born with an accessory pathway which directly connects the SA node to the ventricle, bypassing the AV node. This pathway, as we know, is called as bundle of Kent. It's called as bundle of Kent. And because of this, what abnormality I will get? Normally, when an impulse travels from SA node to AV node does the delay. AV node does the delay. So in the normal ECG, I will have a P wave and then a QRS. And between the P and QRS, I have this PR segment, which is mainly because of this AV nodal delay. But once I have bypassed it, I will not have this AV nodal delay. And because of the absence of AV nodal delay, the time from the beginning of the P wave to the beginning of the Q will become shortened. So one of the important ECG finding in WPW syndrome will be short PR interval. Short PR interval. Short PR interval. So the WPW syndrome ECG is going to look like this. I'll have a P wave, but after that, I may not have this long PR interval. It becomes shortened. When do I call it as a short PR interval? When the PR interval is less than 120 milliseconds or less than 3 small squares. Okay. Now, without the AV nodal delay, electrical impulse has entered the ventricle. As soon as it enters the ventricle, it starts causing the depolarization of the area of the ventricle. Once it starts depolarizing, the QRS will begin early because we know that QRS is the wave of depolarization of the ventricle. So then QRS starts getting depolarized here itself, right? It starts getting depolarized here itself. But then this impulse will only cause depolarization of the small area. Remaining area gets depolarized from the impulse coming from the regular pathway itself. So regular pathways depolarization wave will look like your normal QRS. But because of this early depolarization of a small area of ventricle, we will have this small slant to the upstroke of the R wave, which we call it as the delta wave. So the second important finding in the ECG of this WPW syndrome patients will be delta wave. What is this delta wave? A slanted upstroke of the R wave. So if you look at the normal, R wave just goes up like this straight, right? But here it is slanted because of the early depolarization of the ventricle. Third, because of this early depolarization of the ventricle, now what happened? The QRS started early but ended at the regular time. So what happened to the QRS? It became widened. So we will have wide QRS. Wide QRS. When do I call it as wide QRS? When the QRS duration is more than 120 milliseconds. More than 120 milliseconds. If I get these three features, I am dealing with a case of WPW syndrome. So let us go back and see whether I get those in this ECG. Okay. Usually this delta wave will be more prominent in the precordial leads, that is V1, V2, V3, V4 in the precordial leads, right? That is where you need to concentrate. So when you see this V1, V2, V3, V4, first thing you will notice, right? Let us pick up one of the lead where I can show you clearly. Let us take the example of, let me take to the rhythm strip itself. When you see the rhythm strip, what do you notice? This is a P wave, right? And soon after the P wave is over, there is only a tiny PR segment and then the R wave upstroke starts. So the PR interval here is less than 3 small squares. That means the PR interval is less than 120 milliseconds. So there is short PR interval. Okay. Second, particularly if you look at V4 or V5, you can clearly make out that the R wave upstroke is not straight. Do you notice this slant? Slant and then the upstroke. Slant and then the upstroke. This slant is what we call as delta wave. So in the exam, main thing you have to see is whether you can make out a delta wave. If the context is recurrent arrhythmias and a delta wave is visible, don't waste your time, label it as WPW syndrome, right? So in this ECG, I'm also getting the delta wave. And PR interval is definitely taking more than 3 small squares. It is almost taking 3.5 to 4 small squares. So I also have the wide QRS complex, right? So thus, I have a short PR interval, delta wave and a wide QRS complex, all typical of WPW syndrome. So this ECG is suggestive of WPW syndrome. So diagnosis for this is WPW syndrome. So summarizing it, how do I recognize it in the exam? Only 2 points. Question will be talking about frequent attacks of palpitations, suggestive of recurrent arrhythmias. Which arrhythmias are most commonly occurring in the patients? Most commonly, the arrhythmias that happen in WPW syndrome patients are going to be supraventricular tachycardia, SVT, and atrial fibrillation. So the question may not only mention as palpitations. Instead, question may say that patient comes with recurrent attacks of atrial fibrillation or recurrent attacks of the paroxysmal supraventricular tachycardia, and they give this ECG. The moment you notice that there is a delta wave, you will label it as WPW syndrome. Okay. Now let's go to the next image. Context is a patient with anemia and melena. So whenever there is a patient with anemia and melena, what comes to your mind? Anemia and melena. That means, of course, there is blood loss, right? GI, upper GI bleed. When there is melena, you have upper GI bleed. So this melena is suggestive of upper gastrointestinal tract bleed. Now, what are the causes for the upper gastrointestinal tract bleed? Causes for upper gastrointestinal tract bleed. The first and the foremost, very important, is of course the peptic ulcer, right? The peptic ulcer could be gastric ulcer or duodenal ulcer. Second is esophageal varices. Esophageal varices, right? Third, we can also have GIT bleed because of the carcinoma of the stomach. I can also have upper GI bleed if I have a carcinoma of the esophagus, cancer of the esophagus. Okay. Then there is also one more condition which we classically see in patients with scleroderma or systemic sclerosis. We will call it as the gastric antral vascular ectasia or 𝐾𝐝. Gastric antral vascular ectasia or 𝐾𝐝. Then there is one more condition called as Doylefoy's lesion. Correct me if my spelling is wrong. So these are all possible causes where you can have a upper GI bleed. Maybe this patient has developed anemia because of this ongoing upper GI bleed. These are the possibilities, and there is an endoscopy image, right? Upper GI endoscopy image given, and from the image now I have to identify which of these possibilities can explain this image finding. Okay. Do you see an ulcer here? Does anybody see an ulcer here? No. What do you see? If I ask you to compare this to a fruit, which fruit you can compare it to? Does it look like some fruit? Yes. Which fruit? Right. Watermelon, right? So we call this observation as watermelon stomach. We call it as watermelon stomach. So this is the learning point. Directly they have asked once, where do you get watermelon stomach? Watermelon stomach on endoscopy or watermelon appearance on endoscopy is seen in gastric antral vascular ectasia, right? So in gastric antral vascular ectasia, we see this watermelon stomach. So where is it seen? In gastric antral vascular ectasia. And this 𝐾𝐝, right? 𝐾𝐝 is common in. This is common in patients with scleroderma. Scleroderma. So question may mention that here is a female known case of scleroderma, came to you with melena, endoscopy image. You're seeing this classical watermelon stomach. And then what is the diagnosis? The diagnosis is going to be gastric antral vascular ectasia. Okay. Now let's go to the next image. Again, the context is there. It is an endoscopy image, right? This is again an upper GI endoscopy image. What is the context given here? The context is a patient with heartburn. What heartburn suggests? It is suggestive of esophagitis or GERD, right? As we know, it is suggestive of GERD or esophagitis. Okay. And then another important point is recurrent food impaction. That means this patient, when he takes food, food is getting stuck in his esophagus. Recurrent attacks where he eats food, it's not going down, it is getting stuck in the esophagus. Maybe some doctor removes it with the endoscopy. Recurrent food impaction. And then we have this endoscopic appearance. Endoscopic appearance. Okay, there is another important clue given here. That is 20 or more than 20 eosinophils in the biopsy in per high power field. What is the diagnosis? Two important pointers are there. Food impaction, eosinophils in the biopsy, and endoscopic appearance. So can anybody tell me what is this endoscopic appearance? Sarcastic tremor, yes. Even upper GI bleed you can have in Boerhaave syndrome as well as Mallory. So the list goes on. You can have it in Mallory as well as Boerhaave. How do I describe this endoscopic appearance? No, this is not carcinoma of the esophagus. Do you have any tumor here? Okay, the food impaction can happen in carcinoma of the esophagus, but not recurrent, and of course not eosinophils on the biopsy. So what is this? What I can call this as? This is called as feline esophagus. It's called as feline esophagus. So when you see this esophagus, no, this has horizontal ridges. It's not a smooth tube. It has multiple horizontal ridges, and if you look closely, there are also vertical ridges running downwards. This kind of picture is not seen in human esophagus, usually in the cat class of animals, but now we are seeing it in humans. We will call it as feline esophagus. Feline esophagus on the endoscopy with eosinophils is suggestive of, there's a condition called as eosinophilic esophagitis. Eosinophilic esophagitis. Esophagitis. So any question which talks about recurrent food impaction or feline esophagus or more than 20 eosinophils per high power field on the esophageal biopsy, think about eosinophilic esophagitis. This is the food impaction is a very, very important clue. Okay. Now, can anybody tell me what could be the reason for this eosinophilic esophagitis? Why someone end up with eosinophilic esophagitis? Where do you get eosinophils? In what other disease you get eosinophils? Whenever you talk about eosinophils, you talk about asthma, allergies. So eosinophilic esophagitis is also believed to be due to allergy to food, right? It is due to food allergy. Food allergy. So this person may be allergic to food. When that food go to the esophagus, there will be eosinophilic inflammation of the esophagus. And once the eosinophilic inflammation of the esophagus becomes edematous, peristalsis slows down and the food gets stuck. So when they come to the hospital, doctor notices that the food is stuck in the esophagus. Endoscopically, he will remove. He will also take a biopsy because one of the cause for this condition is like food getting stuck in the esophagus is eosinophilic esophagitis. So he'll take the biopsy. Biopsy report will show that there are plenty of more than 20 eosinophils per high power field. If I have to treat these patients, how will I treat? So these patients can get some degree of benefits from giving PPIs and then food elimination diets. Means as doctors, we know there are plenty of food items which patients can be allergic to. So we will try to eliminate few food items each time from the diet and see is there any improvement. So if after eliminating certain foods, if there is improvement, then probably patient was allergic to those food items, and then we will ask them to avoid taking those food items, right? So two endoscopic images, watermelon stomach is gave, feline esophagus is our eosinophilic esophagitis. Okay, next, elderly male with 25 pack years of smoking, shortness of breath and PFT showing restrictive pattern. Restrictive pattern means decrease in FVC, decrease in FEV1, but FEV1 by FVC ratio still more than 0.7. This is what we call as the restrictive pattern. So whenever we have a restrictive respiratory disorder, what are the possible causes? Restrictive respiratory disorders. Can anybody name? Is asthma a restrictive disorder? No, it is obstructive disorder. It is COPD. COPD is mainly an obstructive disorder, chronic obstructive pulmonary disease. So what are the restrictive disorders? Pneumonia, interstitial lung disease, right? These are all restrictive disorders. So whenever the pattern is restrictive, right, I should think of conditions like pneumonia, interstitial lung diseases. Okay. Then of course extra pulmonary restriction can also be there, pleural effusion and all. Mainly I want you to think of the pneumonia and ILDs. So now I have to decide, should I consider pneumonia in this HRCT image or should I consider ILD? So when you see these images, what do you notice? I want you to pay attention to the posterior part of the patient's lungs. Posterior part of the patient's lungs. Do they look like the honeycomb? Do they look like the honeycomb? Yes, they kind of look like honeycomb. And if you look closely here, I'm not very sure if it is clearly visible to you. You can see dilated bronchi. Dilated bronchi means in this HRCT, I can notice all these dilated bronchi. In fact, here you can see the so-called tram track sign, the bronchial walls running parallel to each other here. So dilated bronchi, honeycomb changes. So what comes to your mind? Radiologically, this picture, we will call it as UIP pattern of changes. UIP pattern of changes. UIP pattern. So whenever I see UIP pattern, what does that actually mean? It means there are bronchiectasis present, right? And too many bronchiectasis, extensive bronchiectasis has resulted in what we call as honeycomb appearance or honeycombing of the lungs. So where do we get this UIP pattern? Radiologically, it's called UIP pattern. Clinically, in the context of an elderly smoker, it is suggestive of an ILD. ILD is of two major types. One of them is idiopathic pulmonary fibrosis and the second one is non-specific interstitial pneumonitis. So UIP pattern is usually seen in patients with idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis. This HRCT is suggestive of idiopathic pulmonary fibrosis. So in idiopathic pulmonary fibrosis, we will have traction bronchiectasis, dilated bronchi, and we will have honeycomb changes, honeycomb appearance. In NSIP, we will have plenty of ground glass opacities. Ground glass opacities. And I want you to remember that the idiopathic pulmonary fibrosis is typically more common in males than females. It is more common in smokers. It is more common in elderly males, not young males, right? And on the HRCT, it presents with UIP pattern, which is characterized by honeycomb changes and bronchiectasis. On the other hand, the non-specific interstitial pneumonitis, this is typically more common in females than males. Exactly opposite of it. It is more common in non-smokers. That is also an ILD. It's more common in non-smokers. This is more common in young females, means less than 40 years of age. Less than 40 years of age. And the radiological pattern we see here is called as NSIP pattern, which is primarily characterized by multiple ground glass opacities. You will have ground glass opacities. Here you will have mainly honeycomb appearance. Honeycomb appearance. And this UIP pattern and thus the IPF carries poor prognosis. And this NSIP carries good prognosis. Good prognosis. Okay, so that can be an image-based question, but context always helps you. So if the question is talking about a male smoker, it is pointing towards IPF. If the question is talking about female, non-smoker, young, and some HRCT with a restrictive pattern, it may be pointing towards NSIP, right? Okay, let's go to the next image now. Story is elderly with tremors and bradykinesia. So whenever you think of tremor and bradykinesia, which disease comes to your mind? You see some elderly man doing some postural changes. Context is tremors and bradykinesia. So whenever you think of tremors, yes, Parkinson should come to your mind. In fact, we have this triad of Parkinson disease or cardinal symptoms of Parkinson disease, which includes tremors, rigidity, and bradykinesia, right? Bradykinesia. These are called as cardinal manifestations of what we call as Parkinson's disease. Parkinson's disease. We already know that in Parkinson's they have tremor which is resting tremors. They are resting tremors. Tremors are classified as resting tremors where tremor is there at rest. Movement may not, like with movement the tremor generally comes down. Then we have something called as action tremor where tremors are not there at rest, but when you try to move, do some voluntary work, the tremors appear. And then we have postural tremor where tremors comes only when the limb is held against the gravity, not at rest, not during movement, but hold the limb against gravity, the tremors come. We call it as postural tremors. The tremor that we get in Parkinson is resting tremor. Okay. The second thing is the rigidity means increased tone or increased contraction of the muscles. The rigidity in the Parkinson disease affects both the limbs as well as the core muscles. So when it affects the limb muscles, in the upper limb, it leads to what we call as cogwheel type of rigidity, because upper limb rigidity means there is some degree of stiffness to the muscles, but the muscles are also having that tremor. So tremor plus rigidity put together we call it as cogwheel rigidity. And in the lower limb there is no tremor, so only stiffness, so we'll call it as lead pipe rigidity. Lead pipe rigidity. Now the muscles of the core, like the abdominal muscles, erector spinae and other back muscles, they also have increased contraction in Parkinson disease because of rigidity. But that increased contraction primarily affects anterior group of muscles more than posterior group of muscles. More than posterior group of the core muscles. Limb though we discussed. Upper limb we have this jerky rigidity called as cogwheel. Lower limb just rigidity, no tremor, we will call it as lead pipe. But the core front muscles are more contracted than back muscles. So when front muscles are more contracted, I tend to bend forward, right? So this results in a stooped posture like you see in this picture. So whenever someone comes with a stooped posture, especially elderly, one of the possibility is this rigidity of Parkinson disease. But then as a doctor, I will get confused because with age, there is osteoporosis, vertebral bones go into osteoporotic fractures, and uske wajah se bhi true spinal deformity can come. So when I see someone like this, it may be Parkinson or maybe truly there is a spinal deformity. How will I differentiate whether it is true deformity or it is because of the Parkinson disease where the front muscles are more contracted than the back muscles? How will I get to know that? All I have to do is ask this patient to lie down on a bed. When he lies down flat on the bed, if there is true spinal deformity, he will still maintain that curvature. This curvature will not disappear. Even when you lie down, it will still be there because spinal cord, the vertebral bones are deformed. But if it is because of the Parkinson disease, that curvature will disappear because the gravity will pull it back and correct it when he lies down. So when that disappears, it is suggestive of Parkinson disease. If the curvature persists, it is suggestive of true spinal deformity. And when that deformity disappears in Parkinson disease, we call it as camptocormia. Camptocormia. So this sign is called as camptocormia. And what does that refer to? Camptocormia is seen in Parkinson disease, right? It is seen in Parkinson's disease. And what does that refer to? It refers to bent spine disappearing on supine position. Disappearing on supine position. So the question may go like this. An elderly with tremor bradykinesia, he came in with a bent spine, and when he was asked to lie down on the bed, this is what you see. What is this sign called as, or what does this indicate? It indicates Parkinson's disease. The sign is called as camptocormia. Okay, good. Let's move to the next image now. The story is a diabetic patient complaining of burning feet. So whenever a diabetic complains of burning feet, what do we think of? We think of diabetic neuropathy. Diabetic neuropathy. That to which type of neuropathy? Because diabetic neuropathy can manifest as different forms. The most common form of diabetic neuropathy is what we call as distal symmetric sensory motor neuropathy. Sensory motor neuropathy. Okay, so that is the context, and an image is given where you can see a small tube to which a small thread-like structure is attached, and that is being pressed on the patient's feet. So they may ask, what is this? Or they may ask what purpose this is used for. Context is already set. We are dealing with a patient with diabetic neuropathy. So this device is called as 10-gram monofilament. In the context of diabetic neuropathy, why are we using it? It is not used for the diagnosis of diabetic neuropathy. So please remember, the investigation of choice for diabetic neuropathy, that will be neuroconduction study. I have to do the neuroconduction study to prove that there is myelin and axonal injury. We will call it as nerve conduction studies, NCS. Now, what is this 10-gram monofilament used here? The main problem with diabetic neuropathy is that as they lose, nerves get damaged, they lose the ability to sense pain. So when they lose ability to sense pain, daily their foot gets through multiple traumas, minor traumas, which normally we feel pain and we look at the feet and take care of it. But these patients are not being aware of some injury happening to the foot. So when injuries accumulate, eventually they will develop non-healing wound, and we will end up calling it as diabetic foot. Now that diabetes also has blocked blood vessels because of atherosclerosis, blood supply to this area is cut, not good. And non-healing wound, eventually we have to amputate their leg to save their life, right? So diabetic neuropathy actually increases the risk of the foot amputation. So as a doctor, I need to know whether this patient with neuropathy is still processing the sensations sufficient enough to protect his feet, or he has lost the protective sensations. So to assess whether there is protective sensation present or not, we use this 10-gram monofilament test. So if they ask you for what purpose it is used, to assess loss of protective sensations. We will call it as loss of protective sensation. So when I touch this filament, it is called 10-gram monofilament because when it touches, as you see here, it is not going to maintain a stiff condition. It bends. When it bends, when it has passed 10 gram of force, after that it bends. It cannot pass any more force. Even if you try to press, it will go on buckling. It will not transfer. So it exerts 10 gram of force. That's why it is called as 10-gram monofilament. So when we touch it to the patient's feet, if they're able to feel it, that means they have the protective sensation. Their limb is not at higher risk of the traumas and eventually amputation. But if they don't feel it, that means they have lost the protective sensation. Their feet is at higher risk of developing diabetic foot and other complications. So 2 MCQs. What is it used for and what is the name? Name is 10-gram monofilament. It is used for assessing what we call as LOPS, or loss of protective sensations. Okay. Next one. A young patient with sudden cardiac death. Simple. It's a very straightforward question, right? Whenever the patient talks about young and sudden cardiac death, what should come to your mind? So please remember, the most common cause for sudden cardiac death overall, means without looking at the age, all people put together, is going to be MI, or you can also call it as ischemic heart disease. You keep hearing the stories, right? He went to sleep, next day morning he was found dead because in the night he had an MI. That's the most common cause. But if you ask me what is the most common cause for sudden cardiac death in young individuals, and similarly, instead of young, the question may mention athletes. So in the athletes and young individuals, it is hypertrophic cardiomyopathy, which is interchangeably used as hypertrophic obstructive cardiomyopathy. So whenever they say sudden cardiac death, I should think of MI and hypertrophic cardiomyopathy. If they add the word young, I should think of hypertrophic cardiomyopathy. Okay. Now, what is the image here? After the death, heart autopsy and autopsy image is there. So what are the findings we notice here in this image? Normal heart would have kind of looked like this. This is my left ventricle. This is my right ventricle. Here somewhere I will have right atrium, left atrium. Okay, the similar image, but what are the changes I will tell you. So this is the left atrium of the person. This is right atrium. This is the right ventricle. This is the left ventricle, and this is interventricular septum. So as you see here, what is the change you notice? One of the important change you notice is that the interventricular septum here has become hypertrophied asymmetrically. It is enlarged, right? It is enlarged. This condition where interventricular septum is asymmetrically hypertrophied, we will call that finding as asymmetric septal hypertrophy. So one of the findings that we get in these patients of hypertrophic cardiomyopathy is they will have asymmetric septal hypertrophy. Asymmetric septal hypertrophy. So I will call this asymmetric septal hypertrophy in simple terms as ASH. ASH. Okay. Second, because of this asymmetric septal hypertrophy, this interventricular septum is encroaching into the left ventricular cavity space. Okay, so that results in obstruction to the flow of blood from left ventricle to aorta. So there will be left ventricular outflow tract obstruction. Left ventricular outflow tract obstruction. Third, it's not the interventricular septum, even the free wall of the left ventricle is enlarged, right? This is the free wall of the left ventricle which is enlarged. So I will call it as left ventricular hypertrophy. Left ventricular hypertrophy. Okay. What else happens here? We are all aware that we have so-called papillary muscles. Like here, we will have the papillary muscles whose chordae are attached to the valves, right? Like you can see there is one mitral leaflet, second mitral leaflet, and here we will have papillary muscles and the chordae which are attached to it. So when papillary muscles contract, they pull the leaflet so that the leaflet does not open in the opposite direction. Okay, but what if this muscle becomes strong? The pull force becomes strong. So we will pull it too much down, more than required. So we call that observation as systolic anterior movement. Systolic anterior movement or motion of anterior mitral leaflet. SAM. This we will abbreviate it as SAM. Asymmetric septal hypertrophy. We can abbreviate it as ASH, and this systolic anterior motion of mitral leaflet, we will call it as SAM. So any echocardiography where ASH and SAM is there, you're thinking of hypertrophic cardiomyopathy. And what else I notice in this image? Important thing that I notice in this image is that this patient's left ventricle now assumes a shape because this interventricular septum is encroaching into the left ventricular cavity space. This left ventricle kind of looks like a banana, kind of looks like a banana, right? That's what we call as the banana shaped left ventricle. Banana shaped LV. So the context, young and sudden cardiac death, and you see, like, you don't have to go through this whole image, you quickly see the left ventricle kind of looks like banana. You know what you're dealing with. You're dealing with hypertrophic cardiomyopathy, right? So apart from this, all these findings are giving rise to a banana shaped LV. Shaped left ventricle. Okay, one last point. What is the reason for someone to develop this hypertrophic cardiomyopathy, right? It is due to mutation in beta myosin heavy chain gene. Beta myosin heavy chain gene. So this is an inherited disorder. It's not an acquired condition. I cannot develop the hypertrophic cardiomyopathy. I cannot acquire it. The gene has to be, the mutant gene has to be passed on to me. Only then I will develop this, right? Whoever has it has the higher chance of sudden cardiac death. Okay. Now let's go to the next image. A 40-year-old with increased FBS and PPBS. So increased FBS and PPBS is pointing towards diabetes mellitus, and here is this image, and they're asking which type of diabetes it is. That's the usual context. Yes, diabetes with this. What is the finding? You can see two things you notice in the nape of the neck of this patient. First, there is pigmentation. Second, there is hyperkeratinization, right? Increased keratin production and pigmentation. So there is hyperpigmentation and keratinization. What do we call this finding as? This finding is called as acanthosis nigricans. Acanthosis nigricans. So in what all conditions you can have acanthosis nigricans? You can have it mainly because of insulin resistance, and sometimes it can be because of an underlying malignancy. Mainly GIT malignancies can also cause acanthosis nigricans. Here the context is high blood sugar. With that, acanthosis nigricans means acanthosis nigricans. Acanthosis nigricans indicates insulin resistance or cancers. One, it can be seen in patients with insulin resistance, and second, it can be seen in GI cancers. So here I should think of insulin resistance. So diabetes with insulin resistance, which type it is? Of course, it is type 2, right? So that means we are dealing with type 2 diabetes mellitus. Type 2 here because presence of acanthosis nigricans. So we all know that there is type 1 and type 2. Type 1 is primarily autoimmune, where there is destruction of beta cells, and type 2 is insulin resistance. Okay. So now, because acanthosis nigricans is sign of insulin resistance, I'm taking this patient as having type 2 diabetes mellitus. Okay. Next image. Here again the context is set. A young female with bilateral headache, and as you see the image here, first point is bilateral, and you see an image where headache is distributed in the forehead, right, temporal parietal region and occipital region. So should I consider this patient as having migraine or tension type of headache or trigeminal autonomic cephalgias? So please remember, when it comes to primary headache disorders, the tension type of headache is the only primary headache disorder which is bilateral headache, right? And as we know, migraine and cluster headache, which is a trigeminal autonomic cephalgia, these are all unilateral headaches. Unilateral headache. So already when I know that this patient has bilateral, I'm already leaning towards tension type, plus this image helps me know more. What is it? This distribution of the pain, right? In the forehead, temporoparietal and occipital region, patients often describe it as a tight sensation. In the examiner's words, they describe it as band-like sensation or vice-like grip. So this image is pointing towards a band-like sensation, band-like sensation or vice-like grip or vice-like grip. So these words are always pointing towards tension type of headache. Whenever you notice these words or such an image, band-like sensation or voice-like grip, you should always think of tension type of headache. Anyway, all migraine, tension type are typically more common in young females. Cluster headache is the only one which is relatively more common in males. Okay. So now tell me, how do you treat this tension type of headache? What is the drug of choice for acute treatment and what is the drug of choice for preventive treatment? Drug of choice for acute treatment. When patient is going through headache, I will give simple painkillers, right? NSAIDs, including paracetamol, are considered as drug of choice. Drug of choice for preventive treatment is amitriptyline, which is a tricyclic antidepressant. Amitriptyline, which is a tricyclic antidepressant. Okay, so let's now proceed to the next image. A patient with weight gain, he has high cortisol and MRI of the brain shows a pituitary tumor. So already information is there. Gaining weight, right? MRI shows a pituitary tumor and the cortisol levels are elevated. So what is the diagnosis we are dealing with? High cortisol. What is it? Whenever cortisol level is high, high cortisol is suggestive of what we call as Cushing's syndrome, right? Cushing's syndrome. And if this high cortisol is because of an ACTH producing pituitary tumor, we will call it as Cushing's disease, right? So this patient is actually having Cushing's disease. And then there is an observation. What do you notice here? There is a hump on the patient's back. So what do you call this hump as? This hump is called as buffalo hump. It's called as buffalo hump, like buffaloes have a hump. Now, why this hump happens in patients with Cushing syndrome? There are a few important image-based questions that can be asked on the Cushing syndrome. Okay, so one of them is that you already know that you can have pink purplish striae. Pink purplish striae. Second thing that you can see in patients with Cushing syndrome is moon face, right? A rounded face or moon face. Third thing you can see in Cushing syndrome patients is weight gain, and thus you can have abdominal obesity. The fourth one is buffalo hump. Buffalo hump. The fifth one is easy bruising. So minor trauma, they bruise. Easy bruising. Why all of this is happening? Purplish striae, moon face, abdominal opacity, buffalo hump and all in case of patients with high cortisol. Please remember, in presence of excess cortisol, like you might have seen people with chronic stress, sleep deprived, they look peculiarly, right? Especially when they eat heavily, they gain a lot of weight and they look quite sick. One of the reasons for that is redistribution of body fat. So under high cortisol, body fat gets redistributed. Where all it goes here. It goes in the chest area. So they can have gynecomastia as well, right? I forgot to mention. They can have gynecomastia as well. And when there is abdominal obesity, the skin gets stretched with the high cortisol, and the cortisol stimulating the melanocortin receptors results in this pink purplish striae. Moon face, rounding of the face is also because of redistribution of the fat. So all of these, majority of these are because of redistribution of fat. Even buffalo hump is because of the redistribution of fat. So this image with the context of the pituitary tumor or the high cortisol, we are thinking of it as buffalo hump, suggestive of Cushing's syndrome, right? So that's it from me on these image-based questions. My other colleagues will continue to take the important images from the individual subjects. Medicine, pure image-based questions are unlikely. Most questions that they come, they will have the context. So you can mostly make the diagnosis from the context or the story itself. So again, I urge concentrate more on understanding the disease symptoms, investigations, how to interpret that. That will help you to solve image-based questions even when you cannot recognize the image. But please don't miss out on learning the images from pathology and radiology. That holds the key, right? So that's it from me today. I'll see you in the next class. Till then, have a good time. Bye-bye.